All right, good morning, everyone. Thank you all so much for joining us this morning for Emory Healthcare's Health and Wellness Speaker Series for DeKalb County School District employees. We are excited to be with you all this month of May, and we have a wonderful presentation for you all this morning on the topic of dementia. And we are lucky to have with us Dr. Monica Parker. She is an associate professor within the Department of Neurology at Emory University School of Medicine. She received her MD from the University of Nebraska at Omaha. And maybe potentially her most important role, she is the Outreach, Recruitment, and Engagement Core Leader and the Education Core member for Emory's Goizueta Alzheimer's Disease Research Center, which is an absolutely amazing program center that you will hear all about. And yeah, we are very excited to have her with us. And so I am going to go ahead and share my screen and we will get started.
Okay, thank you so much, Lindsay, for inviting us. I have met with the DeKalb retired teachers on several occasions before, so I'm always happy to meet with our teachers. And just because my objective is to inform you about dementia, but more importantly, to get you as healthy volunteers to participate in our clinical ongoing observational studies in Alzheimer's and related dementias research. Our focus now in research is less on cure or definitive medication treatment, but really more of how can we prevent this disorder? What are the things we can do to make it less likely that people will suffer from this disorder? And if they do, how can we help them to live a little bit better? So when we start looking at research, there's a lot we know in 2024 that we didn't know in 2019, that we definitely didn't know in 2020, and we certainly didn't know in the 2000s. So let's go with the next slide. My purpose here today is to kind of help you understand some definitions, define Alzheimer's and related dementias, help you identify dementia behaviors, which we recognize and we see, but we're really not always aware of how important they are or they are not. How some of these behaviors can be managed without medication, and probably give you some additional resources that you can use to learn more about this disorder on your own. Okay. So what is dementia? What is a normal neurocognitive disorder? So the proper naming or nomenclature that we're using in medicine is not really dementia anymore. It's really a disorder. It's a spectrum of disorders, and dementia is one part of that. And because it is there, we're learning that this is not a normal part of aging. A lot of people seem to think that as we got older, we gradually lose our function. But I'm going to compare our brain to our teeth. If we take really good care of our teeth, we have them until we no longer need them. They stay in our head. If we don't take good care of them, they come out of our head. In any event, a neurocognitive disorder or dementia is something that doesn't allow somebody to exist independently. They frequently require additional help and support. And that's why it's really important to better understand this disorder, where we can intervene and decrease people's dependency on external help. Sometimes when somebody develops symptoms that look like Alzheimer's or related dementia, it's neither. It may be a medical condition that's causing a disruption in how the brain functions. And because the brain is just not functioning well, the body's not functioning well. And delirium is a treatable medical illness. Okay, let's go. Next, please. Okay, so when we start looking at brain dysfunction or disorders of the brain, what are we looking at? And what really is a neurocognitive disorder? What is dementia? This bit more is when your brain is dysfunctional, it's not just the whole thing is dysfunctional. there may be different parts of the brain that serve different functions that are not functioning well anymore. So on the left side of your screen, you see an orange column that has 6 different titles or categories. These particular categories are called domains. These are the things that your brain helps you do. So there's complex attention, there's executive function, there's learning and memory, and we're pretty aware of what memory loss is, okay? But perceptual motor, making your body work and move the way you want it to, using the proper words in the proper context to get the right message across so that you can communicate with people, that's language. And social cognition, doing socially appropriate behaviors, making the proper decisions. We may call this judgment, okay? Judgment and problem solving. So you can read the blue part, but deficits in 2 or more of these brain functions, there are 6. So if you have deficits or problems with any 2 of these 6 brain functions, we're going to give you a diagnosis of dementia. Does that tell you what's causing it? No, it just means that your brain is unable to do these things. So I'm going to take the second bullet there, the executive function. That's something that you've learned, something you've learned to do. It is your ability to process things, get yourselves together to get on this computer, get yourselves up to get dressed, to feed yourself, to fix your meals, things like that. To drive, to play golf, that's executive function. Some people, when they've had strokes, lose their executive function capabilities. Learning and memory, inability to process new information, can't learn something new, can't follow directions, things like that. That is something that your brain helps you do. Perceptual motor is your brain's ability to coordinate the activities of your physical body, making your arms and your legs move. Okay, so as an example, you want to move from point A to point B. Well, that's coordinated in your brain in order for you to do that. And depending upon what part of your brain is affected, like if you've had a stroke and you had a significant cerebellar stroke, your body's probably not going to be able to move well because that part of your brain controls your movement. Can we move on to the next one? So, what is mild cognitive impairment? If dementia means deficits in 2 or more different brain functions, mild cognitive impairment means you only have the loss of one of those brain functions. And most people who have the loss of one of those brain functions can pretty much function independently and by themselves. They can do what everybody else does because whatever problem it is they're experiencing is not going to interfere with their ability to take care of their own needs. So in research, in Alzheimer's and neurologic research for brain dysfunction, we want to find those people who have deficits in only one brain domain, because that generally means that they're at risk for developing something. We're not really sure what it is, but for people who have risk factors for Alzheimer's, this is the earliest stage at which we may be able to intervene. And intervene may be a medication that may or may not be available at present. It may be a physical activity. It may be a rehabilitative strategy that can be implemented to help improve that person's functional capability and allow them to remain independent. Next, gone. Depending upon what causes it, it may not progress to anything else. So this is a picture, a pie chart, that kind of goes through the different types of dementia that we're aware of or diagnostically aware of, and we've categorized them. 20 years ago, when I was in practice in Social Circle, Georgia, we just put dementia and Alzheimer's in one big pie. It was all the same. But research 20 years later has shown us that these dementias are really not all the same. They're very, very different. And when they're different, that generally means that what's causing them is different. And if what's causing them is different, what treats them is likely to be different. The end result is the same, but they are different. So the most commonly diagnosed to date has been Alzheimer's. And you see, that's the bigger part of the pie. The next larger piece of the pie, or the smaller piece of the pie, is a dementia that is more likely to be vascular, which has to do with hypertension, cholesterol, and diabetes. heart disease. And when you hear that and you see vascular, I want you to think of strokes and TIAs. Then you have something called Lewy body dementia. Many of the people who have been diagnosed with an Alzheimer's type dementia may have a combination of vascular and Lewy body, or Alzheimer's vascular and Lewy body. It may be somebody who's developed an ongoing problem with a substance use, like chronic alcoholism causes a type of dementia, and that's a smaller kind of sliver of that pie. Chronic HIV that hasn't been managed can manifest as a type of dementia. And yes, you've heard about repeated and recurrent head trauma. We call that chronic traumatic encephalopathy, bad head. That results in a type of dementia. So they're different types of dementia. They have different causation. And because they have different causation and problems, there's likely to be a difference in how they will be definitively cured. But the end result is that most people who suffer from any of these disorders are not able to independently care for and manage their own personal activities of daily living, like feeding, grooming, dressing, toileting, mobilizing, walking themselves, or their independent activities of daily living, which are things like paying bills, driving, fixing meals, those sorts of higher social functions that are required to exist independently. Next slide, please. So what are symptoms? Somebody can't remember words. They can't remember phrases. Those are symptoms that something is wrong. It doesn't tell you what is wrong, but when we think of Alzheimer's or a dementia, we generally think only in terms of memory loss. But as science has progressed and research has gone on, we've learned to look at other things that may be indicative of brain dysfunction. Memory loss is one of them. But look at that third bullet, loss of bowel and bladder function. As a primary care clinician, a lot of our patients have, or family members will complain of somebody's inability to control their bladder or their bowels, or to relieve themselves in inappropriate places. A lot of times when people look like they're not able to control their bowel or bladder, that indicates that the nervous system isn't working such that they can recognize when they have to urinate or defecate, and more importantly, get themselves to the right place to do that. That's a brain function. Okay, inability to independently dress, groom, toilet, see that there's food soiling your clothes, and maybe you don't want to put on that dirty shirt or that dirty dress. Some people who have degeneration of the posterior part of the brain, the cerebellum that we talked about earlier, may have trouble walking, may have trouble with their balance. But aside from brain degeneration, if you're dehydrated, you can have trouble with your balance. If you're taking medications that are interfering with your ability to process and to balance, you will have gait instability. Personality changes. People with dementia frequently will have changes in their personality. I've seen all over the spectrum. Some people are very, very pleasant. Some people are extremely irritable and argumentative and very difficult to manage. And when people progress in their dementia, they may start to hear and see things. They may have developed some psychoses. But if they're people who suffered from schizophrenia or paranoia in their early and midlife, as they develop dementia, those symptoms may get worse. But in persons with advancing dementia, these are not uncommon symptoms to observe. Next. So what are behaviors? I practiced at Wesley Woods Geriatric Medical Center for over 15 years. And the things that generally brought people to the doctor weren't some of the things on that other page, but a lot of the stuff on this page. They're wandering. They're getting up in the middle of the night. They're walking out of the house. They're walking around the house because they can't go out. They've started to develop some compulsive behaviors. Maybe it's cleaning the house. Maybe it's collecting stamps. Maybe it's entering sweepstakes. Maybe it is anything that can be, I'm going to call it, can be annoying to other people. Driving difficulties are really very common. People are getting lost in very familiar places. They're having frequent accidents. They're misjudging distance. They're running into poles. They're running up on curbs. They're frequently disabling their vehicles because they've run into something. And then you start to notice dents all along the car. And it's like, well, when did you do this? Well, I didn't do anything. I didn't do anything. So these behaviors are things that have a tendency to drive people into the doctor's office. But I would say to any of you who are on this conference, any of these sorts of things is something that needs to be addressed with their their significant provider, primary care provider. Next, please. Okay, why? Why do you need to go see a doctor? Well, because some of the things, as I've alluded to earlier, may be caused by a medical condition that can be addressed. A lot of our patients who have difficulty in the areas that we talked about are taking their medications correctly, but their bodies aren't metabolizing them, so they're accumulating in their system and they're getting a little confused. A lot of people, and I'm going to put this out here, if you're taking Benadryl and you're over the age of 65, please stop taking it. Why? Why Benadryl? Because Benadryl is one of those medications, yeah, it can make you sleepy, but can also cause you to retain urine. And if you retain urine for too prolonged a period of time, you can induce some kind of toxic problem. You can develop infections and other things. So in addition to seeing a doctor to make sure that we look at medical causes for things that may be treated, when you start to observe these things as family members and people who are nearby, you may want to also enlist the support and advice of an elder care attorney to help you settle and arrange personal, financial, and business affairs of that person. You may also want to confer with a social worker to make sure that we do what we can to keep that person safe in his or her home and make sure that we have provided for the proper quality of life. Everybody with dementia doesn't need to be moved to an assisted living or a nursing home. People can be maintained in their homes, but sometimes a social worker can help us figure out the better way to do that. The social worker can also help family members cope with a family member's changing physical and cognitive status and help us all make better decisions because they're more objective than many of us are personally. Next, please. So this is a slide. I'm sorry you can't see the attribution, but if you've got a pen, and since you're mostly retired educators, I know you have a pen and a paper around. This is what we know about Alzheimer's and related dementia risks as of this moment. This is coming from, it's a consensus report issued by the Lancet Commission, and it's a report that basically put together all we know about research to help us understand how we can prevent dementia, what causes it, what we might be able to do to stop it. And as a result of this research, what we've learned is, and let's go to the top of this, dementia doesn't start at the bottom of the page where you're in your late age after 65. It starts up here at the very beginning of your life, early life. What is helping your brain form? That can be the external environment, your exposure to pollution, the kind of education you receive. And it's not everybody needs to go get a PhD. You need to become literate. You need to be able to read and write. But one of the things that we've learned about early life risk factors for developing dementia later on is the risk of the level of pollution in the environment in which you were raised. People living in places that are heavily polluted are at higher risk for developing later life dementia versus people who are not. An example, environmental kind of pollution. In Flint, Michigan, you had a lot of lead in the water. So a lot of the children who are born drinking and consuming that water are having neurologic problems at birth. Those persons are more likely as they progress through life to have more and more difficulty with the way their brain functions. But we do know that heavy air pollution, soil contamination, the environment plays a role in your risk factor development for developing dementia. As we progress through life, there are other things that we choose to do that have an effect on how our brain functions. Okay, so in this blue circle, you'll see things like hearing loss, traumatic brain injury, you see hypertension, you see alcohol, and you have obesity. So those are some risk factors in midlife that are associated with later life development of dementia. But of those things in that picture, there are several things we can manage. You don't have to develop hypertension. You don't have to become obese. You don't have to become an alcoholic. So these are choices that we can make and where we can intervene to make it less likely that we develop dementia. As we progress along in life, there's some other things that we've noticed that are associated with developing dementia later in life. Smoking history, smoking, alcoholism, hypertension, cholesterol, those are risk factors for cardiovascular disease. And any cardiovascular diagnosis puts you at risk for developing a type of dementia. More likely vascular, but it can also be associated with Alzheimer's in people who have the appropriate genetic risk factors. Things that you can treat or you can manage: social isolation. People who are socially isolated are more at risk for developing dementia. People who are physically inactive are have associated risks for developing dementia. Let me see. Oh, what did I do? There we go. Okay. I talked about air pollution. I talked about diabetes. But diabetes, hypertension, high cholesterol are risk factors or cardiovascular disease. Those things are preventable. And even if you have them, if you're taking medications, take them, exercise, and resolve to do a little bit better. The second purple bullet here, depression. Why is that on there? Because untreated depression looks like it might be dementia. But if you manage it, and we have treatments, effective treatments for depression, you don't generally have that problem. So in terms of how we look at risk factors for dementia, there are things that you can manage and there are things that you cannot manage. We generally don't have a whole lot of control over our genetics, and that is a risk factor, but maybe not as much of a risk factor as some of the other things that are on this list. And the things that are modifiable, again, we have a personal responsibility to check for all the things that we think we can intervene with. We should be getting a hearing test. We should not be enduring loud noises. And for those of us who are parents and grandparents, constant earbuds at loud volumes in our ears predict our forerunners of hearing loss. So those are things that we don't have to do. So if you haven't had a hearing test, try to get one. Okay, next. So what are some of the medications that we use to treat Alzheimer's and related dementias? Let me start out by saying, I don't care what you hear, what you read about, none of the medications currently available cure Alzheimer's or related dementia. Almost all of the medications that we have available to manage this disorder manage the symptoms only. They're not changing the trajectory of the disorder. They're not stopping anything. They're not chemotherapeutic drugs like chemotherapy drugs. So we have several categories of medications. Right now, you've heard a lot about cholinesterase inhibitors. Those are things like Aricept or donepezil, generic name, galantamine, otherwise known as Razidine, Exelon pills or patches. And then they may have something called memantine added. There are now combination products that combine one of the cholinesterase inhibitors with memantine to make dosing easier. Some people may have an antidepressant medication added to their regimen, not because they're depressed so much, but because these medications will have byproducts that will help with some of the behaviors that we see in people with dementia. So when we talk about sleep, people having difficulty sleeping, the antidepressant trazodone frequently helps people sleep. We're not necessarily giving it to them for depression, but it does help with anxiety. It does help with agitation in crowds. And more importantly, it helps with sleep. Mirtazapine, otherwise known as Remeron, is a medication. It is by definition an antidepressant, but it is a medication that can cause people to eat more. It can improve appetite. So unless you were psychotic and had a diagnosis of paranoia or schizophrenia in midlife before you get older, you shouldn't be on these antipsychotic medications. Antipsychotic medications, Risperdal, Seroquel, Geodon, Abilify, Haldol, are medications that have significant poor side effects that make make it more likely for people to lose weight, be sedentary, develop bed sores and other things, but also induce cardiovascular events. So they're not medications for people who don't have a secondary diagnosis of mental health disorder to be on. And if your relatives are on any of these antipsychotic medications and you as a family member decide that you want them to go to a nursing home, they're likely not going to be getting into a nursing home because these medications are on their medication list. Most nursing homes will say, we don't have the capacity to manage people with psychiatric illness. If these are their medications and this is their problem, we're not equipped to manage somebody with a psychiatric disorder. People think, well, if I give them this, they'll go to sleep and I won't have to do anything with them all during the day. Let me just give it to them and keep them calmed down. These medications, unless they have an underlying mental health diagnosis, I'm going to repeat that again, keep you out of nursing homes. They can keep you out of assisted living homes as well. Next. So how do you manage dementing behaviors? Okay, we talked about medications to some degree that may be used and employed in facilities more likely, as opposed to being at home, but they're also used by people at home. But the better thing for managing people who have challenging behaviors in the midst of their brain confusion is to do things that don't require medication. So when you're a caregiver for somebody who has dementia, and even if they don't have dementia, you have to establish a routine that figures in regular activities of daily living, some socialization, some exercise, because a scheduled routine is easier for people to follow. And as people lose their abilities, a routine is much easier for them to participate in. A routine in a familiar environment. I know that a lot of family members say, well, I'll take mom for 2 weeks, you take her for 2 weeks. That's probably the worst thing for mom because she has to reorient herself. And if she's got dementia, she can't do that easily. It's easier to manage her in her own home or the place where she resides most of the time and have people come in to assist her. Keeping places well lit, calm, not noisy, no loud noises, and not with a lot of people coming in and out. Large crowds are frightening to people who are developing dementia because they don't recognize the people, and that makes them fearful. So trying to avoid large crowds and having too many people of different whatevers that they're unfamiliar with in their environment can make them fearful and sometimes make them a little act out a little bit. Give them things to do that they can enjoy doing. If they like peeling potatoes, fixing vegetables, and that's something they know how to do, let them do it. If they want to fold towels and napkins, let them do it. If they want to work in the yard and dig in the dirt, let them do it because that's what they're comfortable doing. That's an activity that is comfortable for people. And you want to minimize too many loud noises. That's why older people don't necessarily like malls and stuff. We may like them, but that might not be the best thing for them. Next. Some other non-medical therapies that you can use to help manage people who have Alzheimer's or related dementia. Music therapy. A lot of people who were musicians, violinists, pianists, they like music, so let them engage in those kinds of activities. Reminiscence therapy, looking at pictures from a time long ago or telling stories if they can do that. Exercise. Exercise early in the day is something that keeps people from getting up and wandering around and thinking they need to go somewhere. So taking people on walks, scheduled walks 2 or 3 times a day, kind of helps get that physical energy, dissipate some of that physical energy, but it also is a little calming. It also helps blood pressure. And then people say multimedia. Okay, let's do the computer. I don't have very many senior patients that can operate too many devices. I'm challenged trying to manage the laptop, the iPad, and the phone, as my staff can tell you. That's why she's doing my slides. And then social engagement, keeping engaged with people and people that they're familiar with. You know, if you go to an adult day program, there's usually not a whole lot of people in there, but they're generally familiar with the people who are there. Keeping their partners or their care partners, other than spouses or children, etc., excuse me. In their environment, the same kind of consistent caregivers. It's kind of hard when you have rotating caregivers coming in the home, doing things like helping with bathing or dressing, because that family member isn't familiar with them, and they may be a little resistant. So trying to keep those kinds of people who are managing helping us live with these persons need to be consistent. Okay, try to find something to do that they enjoy, that you enjoy, that brings them joy and brings you joy. And then there are lots of therapists, there are family counseling, I won't say agencies, but support groups and organizations that can help family members live with people who have dementia and help them cope with some of the changes that are going on. So these are things I always tell my family members who are living with people who have dementia, please learn to be a good caregiver for whatever disease process it is that you're dealing with, so that you understand it better. Joining a support group generally is a way to identify agencies and resources that help us with the journey that we're on. Next. Okay, music. I'm talking about music here simply because we use it as an adjunct to help control behavior. But for people who were musicians once upon a time, this is something that's helpful. For those of us who were upright and may have played piano or guitar, or were performers when they were in junior high school, or even college, how can I preserve my memory? How can I preserve my brain? Pick those instruments up again and try to do something. Because it helps your brain. Music is familiar. It's something that helps people who have anxiety and agitation, particularly if it's music that they are familiar with. We've heard of sundowning, and it's sort of like playing familiar music that was familiar to them in their 20s and 30s, may be soothing at that time of day. Singing and dancing are things that people can do. It helps with breathing. Dancing helps with mobility and balance and gait. And one of the worst things I've seen in people who are in any kind of facility or group setting is people wanting them to sit down. So getting people to get up and walk and move is something that helps stabilize their muscles and helps with their gait and allows them to remain independently mobile. If we don't have enough people to help support them on their walks and keep them sitting, their muscles atrophy, and it makes it more difficult for them to move and take care of their own needs. Next. As I said before, there's no treatment for any of the neurodegenerative processes that I've introduced you to, but there are some medications that you're hearing about. Next. There are more than 37 different Alzheimer's disease research centers in the United States. We're very fortunate here in Georgia to have the Emory Alzheimer's Disease Research Center. It is funded by the federal government to do Alzheimer's research, but also to provide an access point for families to get an evaluation for Alzheimer's and a related dementia. The closest places to us here in Georgia are the University of Alabama at Birmingham and also in Florida. The next closest Alzheimer's disease in Florida, there are 2 or 3 different Alzheimer's disease research centers. One is at the Mayo Clinic in Jacksonville. The other is in Miami. And University of Florida. There are 3 of them there. And in North Carolina, there is Wake Forest, which has an Alzheimer's disease research center. And if you're not in a place where there is a federally funded Alzheimer's disease research center, if your state has a medical school, there's likely to be a memory assessment center or care for geriatric patients associated with that medical center. Next. We have more than 400 different clinical trials going on in the United States, funded by the National Institutes of Aging, National Institutes of Health. All of these studies are not available at all of the centers. This is just giving you an idea of how much money is being spent in research. 65 different trials are for pharmacologic or medical interventional therapies for Alzheimer's and related dementias, non-pharmacological interventions, which have to do with usually the things that I talked about. I want you to see here that of these interventions, exercise is key. Cognitive training, that's things that are repetitive. Sleep disorders research, dietary supplements, stress reduction. I circled music and social engagement. So if you're retired and you are staying socially engaged and you're doing something you enjoy physically and you're a musician, you're probably going to be doing well. Stress reduction and mindfulness. I'm going to bring this up because this comes up a lot in Alzheimer's research as a way to not develop Alzheimer's. It says intervention, but they're looking at all those things. Let's move on to the next one. There are more than 200 different studies going on studying dementia care and caregiving interventions. You can see that most of them are interventions in formal care settings. That has to do with like nursing homes and assisted livings. A lot having to do with caregiver well-being and health. And the other thing I wanted you to see, look down here, there is research on family-based interventions. Does that mean we have them all here? No, they're not all offered in our research center, maybe through the School of Nursing. And then there's palliative and end-of-life care, and then diagnostic tools. So when we start talking about research, there's a lot that goes on in research. And I always encourage people to find the kind of research that they're interested in participating in, simply because as a research participant, you're motivated to learn a little bit more. You learn a little bit more about different disease processes, and more importantly, you learn more about how to better interact with your healthcare provider to advocate and get the kinds of things, information that you need. Next. So why is research important? All diseases manifest differently in different groups of people. So we need to make sure that any of the interventions we come up with, any of the diagnostic tools, any of the treatments that we come up with and prescribe for people are equally efficacious in all groups of people. And believe it or not, even though we know that women live longer, women are more likely to develop Alzheimer's, but women in our center seem to be the predominant participant in our research. But worldwide and nationwide, women are not the most likely people to participate in research. And it's really important with Alzheimer's because we're identifying that in women, that there may be some connection in our hormonal path as we go through life that figures into the development of Alzheimer's for us. Keep going. Is clinical research right for me? We have all kinds of research studies at our Alzheimer's Disease Research Center. And yeah, you're getting this because this is what we do. We need healthy volunteers to participate in the research that we do here in Atlanta through the Emory Alzheimer's Disease Research Center. Next. In summary, I do want you to appreciate that dementia is not necessarily inevitable as you get older. There are signs and symptoms that look like they may be dementia, but with careful medical evaluation, things that can be treated are treated. And that evaluation and that workup begins in the office of your primary care physician. No, I need to see a specialist. No, I need to see a geriatric provider. Well, if you wait to see one, because there are not enough geriatric medicine providers, there are certainly not enough neurologists to see everybody who has a need. It's a major crisis in caring for older adults with neurologic disorders. You're going to have a hard time. The primary care physician that you go to is going to be able to better transfer information and get you to the right subspecialist that you need. So doctor to doctor, we need to talk about symptoms. We need to get the laboratory and other evidence that we have together to communicate with one another to make sure that we do the right things at the right time and put the information together in an orderly fashion such that we can give you the proper diagnosis. There currently is not a definitive therapy for Alzheimer's or related dementias. Yes, you can take vitamins, you can take Prevagen, you can take all of that, but that all figures into eating well, exercising well, and taking care of your chronic illnesses. And there is ongoing research funded by the National Institutes of Health that you pay for that have to do with disease prevention, some intervention, and caregiving. Next, and I think the last slide is a resource side, places you can go so that you can learn a little bit more about Alzheimer's and related dementias. Emily's putting in being a good teacher, she's putting in all the resources, but you can certainly go to our Alzheimer's Disease Research Center website. We have a weekly Brain Talk Live program where we bring in different health professionals from all over the country to talk about different disorders affecting older adults to help us age more healthfully. You can tune in, be a part of our twice yearly brain health forums. And the Alzheimer's Association is the second bullet. But one of my favorites is Alzheimer's University. That's the first bullet. It's like a comic book, www.alzu.org. It's a great way to learn about a lot of the things that I've talked about. And if you go through that, you'll probably learn a little bit more. So at this time, I think we're ready for some questions.
Wonderful. Thank you so much, Dr. Parker. I see that the chat has been very busy, so we will start going through that. I think we also had Emily drop a bunch of resources in there as well. So I'm going to start looking through this, and then as we're answering some questions, I will also work on allowing everyone to unmute themselves if they'd like to audibly ask a question, but also remember you all can use the Q&A function as well as the chat for questions. We did have, somebody had asked in terms of, I guess, research and trials, are participants ever compensated for those?
Okay, that's a good question. So compensation is a relative question. People will generally provide a gift card to help with transportation to get back and forth to the site. But are we giving you an hourly rate for your participation, $20 an hour for your participation? No. Most studies give you some kind of compensation, whether for transportation, parking, or for agreeing to a particular procedure. Most studies give you that information up front. They explain what the study is about, how many visits you will have, and how that compensation will be mandated. There are some studies that say we have 4 study visits. For each visit you complete, we give you $25, $50. For each procedure, we will give you this amount. So it all depends how everybody's study is organized. So compensation is relative. Does that help? Okay.
That's perfect. And so I know it looks like everyone can also check out Emily, who's joining us today, who's also part of the Goizueta Alzheimer's Disease Research Center. She dropped a bunch of great links and information in the chat as well. And I have just gone through and given everyone the ability to mute or unmute themselves. And so we have some time for questions.
Also, if you're interested in research, and while you're getting unmuted, I'm going to give you this number. If you're interested in research here at our center, you need to call Miss Tasha Chapman, 404-727-6050. Tasha Chapman, 404-727-6050. She's the person who kind of answers your questions, gives you kind of like a little memory screen, and lets you know which studies are probably most appropriate for you based on your age and your interest. And, you know, we do kind of like a telephone cognitive assessment to see whether you're healthy or not. And again, just to be clear, we're looking for healthy people. If you have somebody who has symptoms and you're worried about what their symptoms are and you want to get them an evaluation, again, I'm going to point you in the direction of your primary care doctor, because we don't want people in our research who haven't had a full medical evaluation, and research is not a substitute for definitive medical care. Another question, and I don't see anything in Q&A so much, is where do I go to, does everybody on the call have a primary care doctor? Just raise your hand. Do you know how to get one?
We got lots of hands raising. That's great.
Okay, that is good. So if you need a primary care physician and you want one at Emory, we have a geriatric division. And the number you can call is 404-727-6363. That is for the geriatric division. We have geriatric medicine on 3 different campuses at Emory. One is in Montreal Sports and Spine Hospital in Tucker. The second one is at St. Joseph's Medical Center. And the last one is on main campus. Actually, I can't really say main campus anymore. It's more like downtown Decatur. Is that not right, Lindsay? I think
The one geriatrics location.
Right. It's moved to downtown Decatur.
Yeah, it's like close to the square in Decatur.
Yeah. Has a big sign. It's on a corner, but so it's downtown Decatur, St. Joseph's, or in Tucker. Okay, Miss Quinona says the problem with primary care is that they change constantly, and they do change a lot because they may have a better option for managing their families. But if you are in a system, if you're in the Emory system, your provider may change, but your information and your data does not. And why is that important? So in medical care, we talk about continuity of care. So if you hopscotch around and you decide, I don't want to see that doctor at Emory anymore, I'm going to go see this doctor over at Wellstar, or I'm going to go see this doctor at Piedmont 60 Plus, but nah, I don't like any of those people. I like the doctor on the corner. All of those doctors need to have your medical records. So I always advise people that if you're in a system, a comprehensive system that will cover you from primary care to specialty care to hospitalization, that's the best system to be in because your records will be transferable and immediately available to any provider you see within that system. So maybe you're not going to see a doctor in the Emory Healthcare system. Maybe you're in the Kaiser system. Do I need to switch? Not necessarily. See the doctors that are in your system that are covered by your insurance plan. And that's another thing that people don't realize. 30 years ago, 100 years ago, you could go to any doctor you want and think that everything was going to be okay. But now the way insurance is working and the way healthcare is paid for determines where you need to go. So if you're in a Medicare Advantage plan, you need to go to the provider that accepts that Medicare Advantage plan. Otherwise, you're going to have a lot of out-of-pocket expenses that are not covered by your plan. Okay.
We did have a question come in the chat just a few minutes ago. Somebody had asked, how effective are medications at increasing the appetite of individuals with some form of dementia?
Highly variable. It depends on the individual. Okay. That's highly variable. Different people have different reasons for why they're not eating. And let's just go with somebody who's undergoing cancer therapy. They may have cancer. They already don't feel like eating. And on top of that cancer, you're layering some dementia symptoms. It can be any number of things, but medications aren't very helpful. So I'm going to get back to some of that non-pharmacologic things. To help people eat, you need to sit down with them to eat, and they generally try to mimic the behavior around them. One of my pet peeves is people shoving a tray in front of somebody and not opening up the packets and thinking that they can open them up themselves and they'll have the wherewithal to do that such that they can eat. There's a question here about research. Our research folders or our research history is not a part of your medical record. So if you're participating in clinical research anywhere, that is not a part of your medical record. So what you do in our Alzheimer's research is not a part of your medical record. If you want to share that information with your provider, you may do so, but we will not. Okay, so let's see. Please repeat the 2 numbers that were given out. Thanks. So Ms. Hill asked about the numbers. So if you're interested in finding a geriatric primary care doctor, the number is 404-727-6363. If you're interested in research, it's 727, I think 6050. That's Tasha. Okay. All right. When they say someone died from dementia, what would the actual cause be? I have absolutely no idea. That may be something different for everybody. And that depends. What else was going on in their medical history at the time. So those are some of those questions. It's sort of like you can't really answer without having the background information, which is why if you see a Dr. Parker, Dr. Law, or Dr. Trammell out in public and you ask them dementia questions, they're not going to be able to properly address your question because they don't have the benefit of having all of the medical information that's attached to a particular patient. So I always tell people, and my staff is, or team is really familiar with this, is like, oh, please don't give us a personal testimonial because we don't have the information to answer the question appropriately. Okay, Miss Lydia, she says, I suffer from tinnitus since 2009. My hearing's excellent. I have a hearing test every 2 years. Does tinnitus cause dementia? No, it does not. That I can answer. Okay, Emily put the number in the chat for Miss Tasha and for the geriatric primary care. Let's see, I've got a question for you, Lindsay. For people who are who come to the different Emory Healthcare clinics, can you tell people about Emory at DeKalb versus Emory at the main campus? Because now I can say this, we used to have a definitive geriatric outpatient setting and a hospital setting. We don't have that anymore. So, we used to admit our patients that we saw when we were at Wesley Woods directly to Wesley Woods Geriatric Hospital, and they'd be attended to by doctors who specialized in seeing only geriatric patients. Now, older adults are generally seen in the general medical service by a hospitalist. I'm not exactly sure the connection between DeKalb Medical downtown or downtown Decatur and DeKalb Emory Healthcare Hospital on main campus. Can you tell people those differences? I'm looking at the Emory system.
Yeah, of course. So you're just referring to kind of a variety of our locations. So Emory Healthcare, I feel like, is constantly growing and expanding. And back in either 2018 or 2019, we merged with DeKalb Medical. So we now have a handful of facilities that were previously DeKalb Medical, and those are all facilities within DeKalb County. So that's our Emory Decatur Hospital, Emory Hillendale Hospital, our Emory Long-Term Acute Care Facility. And then there's a big handful of outpatient clinics, so primary care offices, some specialty offices that are within DeKalb County that were previously DeKalb Medical, but now they're all a part of the Emory Healthcare system. So in terms of the differences between those and maybe our main hospital, Emory University Hospital on Clifton Road, not really too much of a difference. While yes, they're different locations and some services are offered at one location versus the other, they still all work together all the time. And there's providers of ours who see patients at different locations. Patients frequently get referred in between locations if needed, if there's a specialist at one and not the other. So it's really just a matter of kind of who's where when they're working, and where our experts are that day. So okay, great question.
Yeah. So one thing that I wanted to Lindsay to address was Emory Healthcare. But the other thing I need to tell you is that in terms of neurologic services and trying to see an Emory neurologist, the primary care doctor that's associated with Emory Healthcare can refer you to the Emory neurologist. Emory Healthcare is trying to do their own neurologic assessments and manage their patient population. So if you are not a part of the Emory Healthcare network, chances are you're not going to see an Emory neurologist. You need to see the neurologist that's associated with your healthcare system. Just wanted to put that out there because a lot of people think that you can jump around, and neurology is working a little different from like the cancer services. There's a big difference in how that referral process works. There is a question in the chat about appetite and can somebody die of starvation? The answer to the question is yes. Chronic malnutrition and dehydration is a cause of death for many people who are suffering from dementia because they are not being fed, they are not being hydrated. And it's like, well, I can't feed her, she's not eating, blah, 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 blah. If you are the caregiver for that person, with all due diligence, you have to do the best you can. And at some point, you know, dementia is irreversible. Patients who are at the end stage of their dementia will lose a lot of weight because they don't eat. But families need to carefully consider palliative care and hospice programs early on, because neurodegenerative disorders don't get better, they get worse. And despite your best efforts, and people will lose weight and people will develop bed sores because they're suffering from malnutrition and because they're not being turned and all that sort of thing. Volunteering for different research studies is a different time component depending upon the study. Different studies have different time requirements. Some of our research studies are actually online, just like this webinar is. They don't require you to come anywhere at all. So different studies have different requirements. Thank you, Miss Lydia, for asking that question. But if you're interested, please call Miss Chapman and she can help you find a study that you're interested in. Okay, we're at the top of the hour now, so.
We are, and I also just thought of just another resource to share in terms of what's offered at Emory Healthcare. And Dr. Parker, I believe you might work with this group a little bit, that we have a clinic location that's called our Integrated Memory Care Clinic, which is a primary care office, center that is specifically for folks with a dementia diagnosis. So that's a really awesome team that we have as well, located at our Executive Park location.
So when and I talked to Carolyn Clevenger, they're actually going to be moving out of Executive Park 12 and moving to Executive Park 57. So if you have a relative who has been diagnosed with Alzheimer's or related dementia, and what you're doing basically is managing them and keeping them going from day to day, it's really not necessary to have them see multiple subspecialists, particularly if they're in the latter stages of disorder. The Integrated Memory Care Clinic will provide and manage all of those things, primary care needs, but also agitation as it relates to progressing dementia. They will also, which is not provided in most medical clinics, help you identify and get the social support that you need to help you manage. So the Integrated Memory Care Clinic is a great intervention for people who have family members living with dementia. And a lot of your neurologists aren't abandoning you because they're no longer interested in seeing your relative, but when dementia progresses, it's like a malignancy. There's a limited amount of things that you can do to help that person at that stage. So your neurologist no longer needs to see you on a regular basis unless you're getting some kind of interventional therapy. The primary care and day-to-day management of chronic illness is what needs to be done for somebody who's in the moderate to late stages of dementia. And this kind of medical care need can be managed well by advanced practice nurses in the integrated memory care setting. And your primary care doctor. You don't necessarily need to see the neurologist all the time because you've got end-stage dementia. We just want you to know that so that you don't think that your relatives are being abandoned. They're not. There's just not a need for that subspecialty care.
Awesome. Well, it looks like we have gotten through everything in the chat and the Q&A, and we are now a few minutes past 11. I have a quick little resource to share with everyone if you just want to sit tight for 1 second, but just wanted to say thank you all so much for joining us this morning. Thank you to Dr. Parker and the rest of her team who is on here as well, sharing all this really great and helpful information. We appreciate everyone's time, and we look forward to seeing you all next month.